Today's my topic is, um, hi everyone. I'm very happy to have this opportunity to talk about our experience of using endocytoscopy, and I sincerely hope you all are well under this horrible infection environment. So, okay, let me start the first lecture. My topic is application of endocytoscopy in upper GI, including esophagus and the stomach. Okay. The most basic way of detecting lesions is conventional white light observation. Then we have invented magnifying technology to obtain further and more detailed information about the nature of the lesion. And more detailed information about the and then here. And finally, this endocytoscopy was introduced, allowing us pathological diagnosis during routine screening endoscopy, sorry. And then for detection of the early cancers, spraying dye solution is very useful. In the esophagus, iodine spray is the most reliable diagnostic tool, even more than NBI. Also, indigo carmine is useful to detect the slight mucosal depression and elevation, and crystal violet mainly dyes cytoplasm, so different pathology dyes differently. And there's a reddish, slightly depressed lesion in the middle body of the stomach. Using NBI with magnification, you can visualize the irregular vessels in the lesion. Also, crystal violet helps to recognize the irregularity of the glandular structure. There is a clear boundary between the two areas, cancer area and the surrounding non-cancer area. So magnifying endoscopy, like I'm not sure where your countries are, H260Z or H180Z, maybe in Western countries, has been available for a while. They have approximately 80 folds of magnifying power. On the other hand, ultra-high magnification endoscopy, such as confocal endomicroscopy or endocytoscopy, has magnification power more than 500 folds. The history of contact endoscopy started with the probe-type endocytoscopy. Professor Inoue and Kumagai were the original inventors of the device with the cooperation with Olympus, and then incorporated type was introduced. This is one of the earliest versions probe type endocytoscopy. We insert a probe that has a high magnification power lens on the tip of it through the working channel, and then directly contact the tip of the probe in order to obtain ultra-high magnification images. And this probe-type endocytoscopy has the ability to magnify like 1,100 folds. Still, it requires two sets of whole system, including monitor and processor, which is actually a little bit of cumbersome. And then this incorporated type scope was invented. It has two different lenses. Originally, it had two different lenses on the tip of the scope. One is for usual magnifying endoscopy and one for endocytoscopy. And it has a simple button to switch the lens between conventional observation or endocytoscopy. And then this is the latest model of endocytoscopy. It has only one lens that has the power of magnification up to 520 folds. And of course, it can be used as normal scope. And this is actual screening endoscopy with ultra-high magnifying power, you can say. So on the right, upper right picture, what do you think this is? And actually, this image was taken by Dr. Kumagai, who is one of the original inventors of endocytoscopy, and he gave this picture to me. And this, this is the endocytoscopic observation of his white hair. So it can be this endocytoscopy can be used as the usual scope with super high magnifying power. So when he took this picture, he figured that his white hair was unexpectedly beautiful. As you can see on the slide, the diameter of the scope is no larger than conventional zoom scope, which you may use for screening. But when you conduct endocytoscopy without proper dyeing method, you may not get clear image of cellular structure. Therefore, we invented this mixture solution of crystal violet and methylene blue. Methylene blue mainly dyes nuclei, and crystal violet enhances the cytoplasm. With this solution, we can obtain the image close to hematoxin eosine staining, which is relatively familiar and easier to comprehend for us. And with no staining, you may recognize nothing, like just the vague red image, just like the left picture on the top of the slide. But after spraying CM double staining solution, the cellular structure with clear nuclei image can be obtained. This image was taken from the esophagus, and you can see the squamous epithelium without the no abnormal change. This is a normal mucosa, you can see. And this is stomach, and same as esophagus, crystal violet and methylene blue solution, mixture solution, allows us the clear imaging of surface structure. The difference is that gastric mucosa has glandular structure, which is important to evaluate the differentiation type of gastric cancer. This is actually, the actual observation. Before endoscopy examination, we wash the mucosal surface with clear water to remove mucus and bubbles. It is quite important, especially in the stomach. Then we approach closer to the target slowly and gently, and then up the zoom, just like this. Now I'd like to start showing actual cases. This is an early esophageal cancer, 02C in the mid-esophagus. NBI magnification revealed the B1 abnormal IPCLs on the surface of the lesion. You can see the dot-like IPCLs slightly dilated. So we predict the lesion is mucosal cancer. Then we conduct endocytoscopy. Left picture is taken from the surrounding background mucosa, and right picture was taken from the cancer area. You may see you may recognize the clear difference between two images in the size of the nuclei. In the left picture, a small dot is each nuclei is recognized as a small dot, but in the right picture, the nuclei is largely swollen and highly irregular. So this is the difference between the non-cancer and the cancer. So if you focus on the few layers of the surface of H&E stainings, you can see the lower pictures are the pathological images. So if you focus on the few layers of the surface, the two endocytoscopic image and pathological image is quite alike, very much alike. So only the so endocytoscopic image is like a horizontal section of the pathological image, and pathological image are usually this vertical section. So that's the difference, but the two images are quite alike. And you may see the borderline between cancer and non-cancerous area very clearly. In the right part of the image is non-cancer, but in the middle there's a line, borderline, clearly recognized there. And in the left part is a nuclei is enlarged and the number is increased, so we can predict the lesion is a cancer. And we conduct the ESD to this patient, and it was actually M2 cancer. This is the regional EC classification, categorizing EC images into 5 categories, depending on the NC ratio and cellular arrangement. The size of each nucleus is larger in 4, ECA4 and 5, which are corresponding to high-grade neoplasia or cancer. We invented this ECA classification following to Papa Nicolau classification. I think we thought it was easier to you know, comprehend for the site and following the cytology field. With this classification, the results are tolerable with overall accuracy greater than 90%, 93%, cancer versus non-cancer comparison. This is modified EC classification. We simplified and classified we categorize the pictures into 3 different groups, consisting neoplastic, intraepithelial neoplasia, and cancer, which probably this will be easier to understand, simpler. This is the results from our institution again, and then accuracy was sufficient, we believe. With this kind of incorporated single lens endocytoscopy, we can observe not only surface cellular structure, but also intraepithelial microvessels. If you maximize the magnifying power, you may see the most surface cellular structure, just like the right picture on the slide. But if you lower the magnifying power a little bit, then you can focus on the IPCL, the microvessels intraepithelial in the intraepithelial area. Just like the image, you will see the image on the left side. So this is actually a very interesting observation. This is you may have seen this IPCL classification invented by Professor Inoue in 1997. It is more than 20 years ago. You can see the difference between the normal vessel and the cancer vessel. In the cancer area, the IPCL is dilated and caliber is very irregular, and the shape is also irregular. You can see the difference. You can see the detailed structure of this IPCL with this endocytoscope. In the left picture, it is the highest. It is a maximum magnifying power, and in the right 2 pictures, we lowered the magnifying power a little bit, and you may focus on the IPCLs in the intraepithelial area like this. Top 2 pictures on the top of the slide, they are non-cancer. A little bit of inflammation is observed, but it is non-cancer area. IPCL is very thin and clear, but in the cancer area, so 2 pictures on the bottom, the nuclei is enlarged, and also IPCL is very thick and enlarged and irregular in the right picture, you may see. So this is the movie. in the left picture, that left movie is showing the surrounding non-cancerous area. The to switch the NBI to white light, and also the shift of the lever may allow you to observe the surface structure, surface cellular structure, and at the same time, the IPCLs in the epithelial area. You may see the difference between two and the size of the vessels. If you look closer into each microvessel in non-cancer area, the IPCL allows single red blood cell passing through. On the other hand, the IPCLs are large enough to allow multiple red blood cells to run in the cancer area, which indicate the size of each mic vessel. We can do that. We can analyze the size of the vessel on this with this resected specimen or biopsy specimens, but in the living tissue, it is actually kind of very interesting. The slide shows endocytoscopic findings of IPCL pattern. Abnormality of the vascular shape are more severe in lower pictures. This is cancer pattern. So the reported accuracy so far has been sufficiently high in previous manuscripts, just this. So we move on to the stomach. This is the EC classification of the stomach. EC1 is non-neoplastic. There is no irregularity or cellular or nuclear abnormality seen in this picture. And then in the middle, this is adenoma. This glandular structure is a little bit swollen, and the swelling and irregularity is can be seen a little bit. And then in the adenocarcinoma, you may see the enlarged nuclei and irregularity of the glandular structure. The results are almost the same in the stomach. So this is the early gastric cancer case, and in the antrum there is 2C lesion with white light and NBI. And with NBI magnification, relatively regular glandular structure is still remained. Therefore, we can predict the lesion as well differentiated adenocarcinoma. And if you use endocytoscopy, compared to background mucosa, enlarged nuclei and increased cell number are clearly recognized in cancer lesion, but their glandular structure is still remains. So we can predict the lesion as the well-differentiated adenocarcinoma. This is the movie from the cancer area and non-cancer area. So probably very much different in the size of the nuclei and the arrangement of the cellular glandular structure here. And then this, the lesion was diagnosed as well-differentiated adenocarcinoma pathologically. This slide shows poorly differentiated adenocarcinoma. Actually, there's no glandular structure seen in the enlarged nuclei are randomly arranged. This is typical pattern of poorly differentiated adenocarcinoma. So let's move on to the non-cancer lesions here. This is an esophageal mucosa with severe inflammation due to GERD. The number of papilla is increased and a few inflammatory cells are recognized. This is not cancer, but heavily inflamed epithelia here. And this is another case. This is eosinophilic esophagitis. So you may recognize the small cells, smaller than normal squamous epithelium, small cells with multiple nuclei, which we think may be eosinophils or some kind of inflammatory cells. So we can observe the inflammatory cell infiltration in living body. This is a pathological image, and you may see that their two pictures are very much alike between to each other. And this is another example of EC endocytoscopy use. This is one of my original works, and we analyzed the esophageal mucosa of achalasia patients before and after POEM. Before POEM, the mucosa is whitish and very much thickened. But after POEM procedure, the achalasia, this is achalasia case, of course, and 3 months after POEM, surface vessels are clearly observed, which was impossible to be seen before POEM procedure. And we counted the number of surface cells before and after and compared to pictures before and after POEM. The top 3 pictures on the top were taken before POEM procedure, and 3 pictures on the bottom after POEM procedure. But maybe you can clearly recognize the difference in count of the number of nuclei observed in the cell, observed in the surface of the esophageal mucosa. With this cell counts decrease and MIB1 index and P53 positive cells, I report this phenomenon to BMC gastroenterology, and we wanted to show that POEM procedure may contribute to decrease the esophageal cancer after for esophageal achalasia, to decrease the number of esophageal cancer with POEM procedure. And that was my work. And this is Dr. Sumiyama from GK University Hospital. He reported this very impressive two images. The picture on the top is in vivo cellular imaging of muscularis propria. You can see the muscular fiber clearly with endocytoscopy in vivo. And also, this the lower picture is ex vivo cellular imaging of myenteric neurons, and this is very interesting. And it may lead to some more new knowledge with this kind of work. So let me conclude. Incorporated type endocytoscopy enabled us from regular endoscopy to ultra-high magnifying endoscopy continuously. And risk of hemorrhage after biopsy can be avoided using optical biopsy. Combined use with AI will open many doors to more precise and advanced diagnosis with endoscopy. Thank you very much.